Good morning. Today we are talking about factors affecting the functional development of dental arches and occlusions. And we are talking about there is a lot of changes in occlusion right from the birth to adulthood. It's a continuous process where there is a lot of changes will going to occur. We should know it, what is right and what is wrong at particular ages. From birth to adulthood, dental occlusion undergoes significant changes. The term of occlusion refers to the manner in which the maxillary and mandibular teeth articulate. And it's easier said than done. The whole process is in fact complex series involving morphology and angulation of teeth, roles of muscles of mastication, temporomandibular joint, the skeletal components of functional jaw movements. In an earlier discussions, the growth and development of dental arches and occlusion has already been emphasized. This presentation aims at giving an insight at the various factors that play an active role in the formation. In nutshell, the whole process can be summed as follows. Development of phases of dentition from birth to adulthood. Birth to complete eruption of deciduous teeth, that is till the 2.5 years, 3 years. Completion of deciduous dentition of eruption of first permanent molar from 2.5 to 6 years. And mixed dentition period from 6 to 12 years. Permanent dentition period is around anything about 12 years and above. That is the adulthood, you can say. And these are the primary and the permanent tooth eruption pattern. Central incisors normally in the primer 8 to 12 months and lateral 9 to 13 months and canine between 16 to 22 months. First molar, deciduous first molar 13 to 19 months. Second deciduous molar is around 25 to 13 months. It's almost similar in the maxillary and mandibular, maybe around 1 or 2 months here and there. And the permanent central incisors are 7 to 8 years, 8 to 9 years. The lateral incisors, canine 11 to 12 years. First premolars around 10 to 11. Second premolar 10 to 12 years. First molar 6 to 7 years, and then second molar is 17 to 12 to 13 months. Third molar in 17 to 21 years. In lower teeth is around 6 to 7 years, 7 to 8 years lateral incisors. Canines 9 to 10 years. Second premolar 10 to 12 years. First premolar around 11 to 12 years. First molar 6 to 7 years. And second molar is 11 to 13 years, and third molar is between 17 to 21 years. The functional development, it includes the bone relations, eruption of tooth, and the intraoral forces, tooth relations, and occlusal forces. What do I mean by bone relation? The position, size, and relationship by which the maxilla and mandible relate to one another, and other bones is governed by the variety of factors. These bones varieties are maybe hereditary, congenital factors which may not be hereditary, and hormonal imbalances, traumatic and pathological conditions. Tooth relations, how do they get related? Some evidence suggests that tooth development is strongly linked to hereditary control. The permanent incisors develop lingual to the roots of their predecessors. Maxillary canines develop high in the maxilla, close to the floor of the heartbeat, and mandibular canines develop near to the inferior border of the mandible. Premolar crowns develop between the roots of deciduous molars, and the lower permanent molar develop at the root of the coronate process oriented with the mesial inclination, which in course the eruption takes a curved path in upward and forward direction. The upper permanent molars swing downwards and forwards as they erupt through an arc of a circle whose centers is in the region of apex of the next tooth mesially or in the hammer. Sometimes a defect in the development process may be observed by the presence of ectopic a tooth or an impacted tooth. One tooth shown to have high degree of impaction to occur are the maxillary canines. One of the reason is postulated for this occurrence is the remoteness in the eruption pattern of this tooth. It may be because of the longest direction or the longest path which takes an eruption. Mandibular premolars are known as the ectopic eruption pattern. Although this is a very rare occurrence, etiology for this behavior is thought to be because of the deep position of the tooth buds between the root apices of the deciduous molars that give an freedom to wander. Eruption. How is and why is about the tooth eruption are satisfactorily explained by theories put forth by various authors. There is however, no single theory that gives a clear definition on how tooth eruption occurs. Blood pressure theory, soft tissues at the developing end, the tooth are very vascular and increases in the vascularity has been observed in cases of rapid tooth eruption. Root growth theory, this theory postulates that tooth eruption is accompanied by the growth of the root, but variations of this occurs such as a tooth may fail erupt even though root formation is over. Again, cases of tooth eruption are known to occur at birth with very little root present. Epithelial coil theory suggested by Warwick James. It states that epithelial remnants of tooth band and organ cause a progressive channel for tooth eruption. These epithelial coils found above the tooth determine the site of eruption. Then Hamlock ligament theory suggested by Seacher. He says that the tooth in the crypt is surrounded by a band of fibrous tissues which is present at the apex of the root and is attached to the bone halfway of the wall of the crypt. At this point are present many fluid droplets which act as a cushion to protect the developing tooth journey. Intraoral forces. At the time of tooth eruption, the roots are separated a considerable distance from the socket wall. This gives a chance for a lot of play in the tooth. Due to this, various forces may act during the eruption of the tooth and cause it may be deviated in its eruption. These forces may be from musculature of the lips, cheeks and tongue, may also be from mesiodistal forces exerted from the adjacent teeth. It is to be understood that muscles are never at a state of rest but in a state of tonicity. This means that a small proportion of fibers, even at rest, are always in state of contraction. Forces generated by the muscles may be active or passive. Active muscle forces exert forces that are greater forces and frequency, and the pressure exerted is only intermittent. The example of such forces is that deglutition. The others include speech, mastication, expression, and passive muscle forces are continuous but light, mainly due to muscle cramps. Examples such as muscle systems include the buccinator mechanism, tension from the orbicularis oris. Lip and cheek pressures lost due to topical diseases. The teeth have moved out buccally because of pressure from the tongue, no balancing forces from the buccinator and orbicularis oris. Occlusal forces. It is a well-known fact that the in adult dentition, the teeth are held in close approximations with each other because of the tendency of the posterior teeth to move forward. As a result, at the time of eruption, there is a chance of crowding in the dentition to occur. Upper and lower alveolar borders grow in a direction that is outward and forwards, as pointed out by Brash. He is also suggested that evidence of this as the curvature of the roots. This forward movement of the dentition may, however, prove detrimental in cases where tooth becomes lost because of some pathology. During this time, the tooth just distal has a tendency to tilt into that space. This can result in loss of contact with the opponent, resulting into a malocclusion. Thus, a pressure is transmitted mesially from tooth to tooth. The upper incisors are thus prevented from moving mesially by lip pressure, and the lower incisors are prevented by overbite of the upper incisors. And lastly, the trajectory theories of forces given by Wolff law. A bone is the hardest material in the body and at the most plastic. It is this resilient feature of the bone that is taken advantage of the meeting the various demands of functional forces. From historical perspectives of the first studies on the functional of the bone were done on the femur. In 1867, Werner Mayer and Kuhlmann occurrence of stress lines on the long bones like femur, and Julius Wolff in 1870 propositions of trajectoral theory of forces, the Wolff law. In 1881, Wilma Rooks a biological basis for bone formations, and 1925 Benning of a beam of hypothesis. The story unfolded in 1867. Anatomist Weimar George, while drawing the pattern of trabecular architecture in long bone femur, realized with the help of Kuhlmann, who was engineer visiting George, that the trabeculae followed a certain pattern similar to the internal stressor patterns seen in the Fairbairn crane that is he was designing. However, it was only 2 years later that anatomist and orthopedic surgeon von Meyer, while doing his dissertation on the normal and abnormal bone formation in the animals, brought to light that the pattern which Meyer-Kuhlmann saw were in fact stress patterns produced as a result of bone adaptation to functional forces. He brought out a law based on these trajectories of stress patterns he observed, which came to be known as Wolff's law. Wolff's law. The law states as follows: every change in the form of a function of a bone or of their functions alone is followed by certain definite changes in their internal architecture and equally definite secondary alterations in their external conformation in accordance with mathematical laws. In truth, Wolff's law laid mathematical formulae for the development of such internal stresses, and it was around the same time that Rooks in 1881 propounded that bone formation occurred as a result of stresses of tension or pressure on the bone. He hypothesized that apposition and resorption by cells determines change in bone structures, and that this change is brought about by action of local forces. In fact, gave an insight to the biological phenomena behind this occurrence. In 1925, Benning suggested a beam hypothesis after studying lines of stresses in skull. He postulated that these lines were trajectories corresponding to the functional stresses. The trajectories in maxilla can be are broadly classified as horizontal and vertical trajectories. Horizontal trajectories are hard palate, orbital ridges, zygomatic arches, palatal bones, lesser wings of sphenoid. And vertical trajectories are frontonasal buttress, malar zygomatic buttress, and pterygoid buttresses. These are vertical trajectories. One of the differences of the beam hypothesis is that only mechanical stresses resulting from bite forces on the dentition are considered. In many instances, mechanical stresses resulting from muscle contraction produce a large bending moments and therefore large bone strain adjacent to the several cranial and facial sutures such as the zygomaticotemporal and reaction forces from the temporomandibular joint. In conclusion, this presentation has aimed at revealing the information on the functional factors that affect the developing dentition. An orthodontist can establish a perfect occlusal relationship, but unless he takes into consideration the effects of the use of these teeth, unless he makes an allowances for the manifold environmental functional influences and delicately responsive bony structures are apt to change, and the tooth positions will change with them. Thank you.